She is a master's prepared registered nurse with over 24 years of experience in a variety of clinical settings. She's currently the Western Region Clinical Science Liaison and Infection Preventionist for PDI. Amanda joined PDI from Kindred Hospital, where she was the Chief Clinical Officer, Infection Control, and Employee Health Nurse, and the West Region Resource ICP, where she utilized her skills in epidemiology and clinical management to reduce healthcare-associated infections and increase patient safety. She has also served as corporate nurse quality consultant and infection preventionist for the Aurora Innovage Greater Colorado PACE program, and as an instructor and program coordinator of the LPN and CNA programs in Vernal, Utah. She earned her Bachelor of Science in Nursing at the University of Northern Colorado and her Master of Science in Nursing, with an emphasis in infection control and epidemiology at American Sentinel University in Colorado. She is board certified in infection control through CBIC, and she currently resides in Denver, Colorado with her husband and her daughter. Amanda, we're excited for your presentation this afternoon.
Thank you so much for that great introduction. Yes, good morning or good afternoon, wherever you may be, and welcome to our presentation on the ABCs of FTAG IPC. As Brenda mentioned, I am an employee of the clinical team of PDI, so that is my disclosure. So, the objectives today, I would really like to review FTAG changes in long-term care for infection control and prevention. And we're going to define each of those phases of the programs with the changes that are in place, and help you guys to understand what a well-established and all-encompassing infection control program really means. Where I'll talk a little bit about surveillance in long-term care and NHSN and how you can do that in NHSN. There's a lot of benefits around that, so we'll be looking at that. And then we'll talk a little bit about hand hygiene and employee health programs, as well as talking about antibiotic stewardship and what the expectations are with that. And then we'll talk about what an IP really is and what that expectation is. So, long-term care settings present challenges for infection prevention, as all of you who are on the call probably know. Many residents are very elderly. That means they're going to have weakened immune systems, and they don't often present infections in a typical manner. Confusion might actually be the very first symptom of a resident that has an infection instead of the typical presentation of fever. And also, these settings have shared common areas, they have shared equipment, there's shared air circulation. There's all these frequent social gatherings, people gather in the dining rooms, they eat together, and all of these things present increased risks for infections. So one of the most frequent citations in long-term care is an infection control citation. And so the regulations, they expect and they want long-term care facilities to have a really structured, really well-developed infection control program. And this program should be investigating infections and controlling the spread of infections. The goals of the program should be to reduce overall healthcare-associated infections, which really ultimately also helps lower costs of care, and to help prevent any physical harm that could occur as a result of the infections. So in 2016, there were 3 phases of updated infection control regulations that were rolled out by CMS for long-term care facilities. And the compliance with these each has a deadline. So this is kind of what they look like. This chart kind of shows the old FTAG versus the new FTAG, and as well as the addition of the 2 new tags. So the 2 new tags is F881, which is antibiotic stewardship, and F882, which is your addition of an infection preventionist. And then these are the deadlines that are expected. So you should already be well into having a good and well-established infection prevention and control program, because that was expected in November of 2016. You really should already be doing some antibiotic stewardship kind of things in your facility. And then the next expectation is that you have a trained infection preventionist in your facility by November of 2019. So let's start out with talking about phase 1. So in phase 1, you see the broadest scope of the regulations that are represented. In particular, the expectations around what an infection control program should really look like. And the expectations are that the program is well established. It includes written standards, policies, procedures around surveillance within the facility, the reportable conditions, and the following of certain types of precautions, such as standard transmission-based precautions, and isolating a resident when it's warranted to prevent the spread of disease. Also, really, a good employee health program should be in place. You should have a hand hygiene program in place, and there's evidence that safe handling of linen is occurring. Also, staff should be aware, what those facility policies are around infection control. They should be following them, and they should have been educated. They also need to be have competencies that are in their educational file. You should be able to pull those out for surveyors when they come in. And then at the end of the year, or whenever you decide to do it, at least annually, a review of your program should be done, and a new risk assessment as well done. So some examples of common FTAG citations in the long-term care setting. And if you've been through a survey, you probably have had one of these if you've ever been cited during a survey. So these are kind of some common ones, like glucometers that we used for multiple residents that weren't cleaned properly between use. You weren't, actually cleaning the glucometers based on manufacturer recommendations. And then any sort of hand hygiene or PPE sort of citation, that could be around anything. When there was dressing changes being done, or wound treatments, or somebody was administering eye drops, they weren't wearing gloves, or they weren't following proper, hand hygiene with that. There's a lot of citations based on poor infection control in the dining room. You see that a lot. There's been citations around oral medications that were handled with bare hands, incorrect catheter procedures. There's definitely been citations around like scissors that weren't sanitized, in between dressing changes from one resident to another. And it kind of goes on, there's other ones, and I won't go through them all, but these are just some examples of common citations in the long-term care setting. And if you have a good infection control program, you should be able to avoid these. So we'll be trying to talk around what you can do to help your facility avoid these citations. Okay, so let's talk first about surveillance programs. So what exactly is expected of a facility in terms of surveillance? Well, the regulation states that infection surveillance systems need to be in place to identify and stop the spread of disease. And the facility knows what diseases are reportable, and they will report them when they occur in the facility. APIC actually kind of has a statement around this, and they say that surveillance should include activities that, one, protect the patient, and two, protect the healthcare worker, any visitors, and any other people in that healthcare environment, and that the program really helps to keep costs down at the same time. So what is included in a surveillance system? So there's different methods for performing surveillance. Two most common methods are comprehensive and targeted. When you're determining which method to implement, you got to consider your staff time, you got to consider available resources, and the frequency of events being monitored, and also your goals. So comprehensive surveillance, which is also referred to as facility-wide surveillance, is really an approach that involves tracking all infections among residents in the facility. And having a tracking method, like you might have an Excel spreadsheet where it's all kept. This type of surveillance is you're tracking everything. You might be tracking the smallest cold that somebody has, every fungal infection, every rash, really across the board, just very, very detailed. The benefit of this surveillance method is that a facility, you'll be highly likely to identify all the infections that are occurring of the residents in that facility, and you'll be well ahead of any issues. However, This is really time consuming, right? And resource consuming. You may not be able to do this, particularly for larger facilities. So it really limits also the opportunities for analyzing the data and then doing some infection activities around prevention. So a facility that conducts targeted surveillance, which is also referred to as priority directed surveillance, focuses surveillance activities on high risk preventable or high consequence infections significant to the population. So most facilities in this day and age do this, right? This is kind of where most people have gone. So, for example, by focusing on device-associated infections in a high-risk unit, such as a skilled nursing or like ventilator-dependent type of unit, you can really have a more focus-directed or priority-directed surveillance. So, when conducting surveillance, you should really be using a clearly defined surveillance definition with definitions that are really collected in a consistent way. And this helps to ensure accurate and comparable data, regardless of who's performing the surveillance. If you get into NHSN, this is kind of what the NHSN website looks like. This is a snapshot of their website. They have long-term care facility modules that provide these standard definitions. And it really helps to consistently apply well-defined data elements that will give you like reproducible and comparable data to other facilities. You want to be able to compare your facility to like facilities who are doing the same thing as you, using the same definitions as you, so that you can tell where you stand as far as your infection control program and your healthcare associated infections. And since NHSN protocols closely align with the McGregor criteria, this should be pretty familiar. You know, folks should be familiar with applying this criteria. Okay, so this is an NHSN. These are the long-term care facility components that are available. The first one's the UTI component. The second one is the Lab ID module, which includes any multi-drug resistant organisms as well as C. diff. So that's another thing that's going to be reported. And then the third module is prevention process measures, which include hand hygiene and gowns and gloving. So each of these components, there's training materials, there's videos available to view on the NHSN website. And as far as I know, so far across all states, participation in these modules is voluntary. However, I expect that this will probably go to not voluntary in the near future. I'm not sure how soon, but I expect that NHSN will start requiring long-term care facilities to report these modules. And a piece of that is because they've really built up the system to be able to allow long-term care facilities to do this. And it has been voluntary so far, but everything is in place for them to now require it. The next thing that actually has been put in place, brand new, May of 2018, is this full manual that's available for the long-term care facilities. And when I've worked in the acute care side in the hospitals, they have one of these for the acute care side, and this is your go-to document. So this is something that when NHSN starts requiring folks to be reporting, you will refer to this over and over and over and over again. So it'd be really good if you went to NHSN, downloaded it, printed it out, and start becoming familiar with this particular document. It will give you everything you need to be able to report to NHSN. It also has all the definitions in there of the modules that we just talked about. Okay, so to prevent outbreaks and spread of other types of infections, facilities really should have a method to track symptoms that might indicate an outbreak is occurring. Each facility might have a different method of doing this, but really the most common is just to have a little form out on the unit that caregivers can check that helps identify and catch events that might be happening on the unit before you have a big problem. So for example, if you have 2 or 3 residents on one side of one unit and they suddenly come down with cough, sore throat, fever, and your caregiver has checked that and then turned it into your infection preventionist, that's going to indicate potential flu, right? Or it could be a lot of other things as well. But that really helps to get ahead of the curve when you're looking at catching outbreaks on your unit. So if you're not already doing this, this might be a good thing to start implementing in your facility. Every long-term care facility should know which conditions are considered reportable for their state. Each state has something a little bit different, but it's going to be similar to this. This is Colorado, and as Brenda said, I live in Denver, so this is the one that I pulled up and that I'm familiar with. But everyone in our state, in the state of Colorado, including all long-term care facilities, have to report these particular diseases in Colorado. This list is going to vary, and it not just varies year to year, but it also varies if something is coming into our state and there's something new that's emerging in our state. They will update this particular form. So, and your state, wherever you're at, is going to have something just like this. And if you don't already have this printed out, this should be printed out on your wall somewhere so that you know which diseases are reportable to your state. And also, you should be signed up. If you're not already signed up, you should be signed up to receive updates from your health department. And if there's some, new things that are added to this list at any time because there's something that maybe is emerging in your state, they will send you updates and email updates if you're signed up for them, which is really, really nice. And then you can go back to this list and say, oh yeah, they added whatever it was, they added something to the list. And so now we need to be sure that we're reporting that as well. So, knowing your reportable conditions and keeping this list very updated and knowing which things that you need to report is an important part of your infection control program. Okay, so let's talk a little bit about isolation and infection prevention measures. The regulation states that facilities are supposed to be following universal, standard, and transmission-based precautions when needed, as well as, you got to isolate residents when it's required, right? So occasionally when a resident has something, maybe C. diff or whatever it is, you're going to have to isolate them. But this comes with challenges, right? Because you've got to balance other residents being exposed while still maintaining the resident that's isolated, their physical and psychosocial well-being. And that's not always an easy thing to do. But when it comes to isolation, CMS really recommends taking the least restrictive but adequate approach to protecting staff and visitors and any other residents, as well as the resident with the infection. So what they say is that the least restrictive approach means maintaining isolation precautions for no longer than necessary. And that's kind of a hard thing to do, and it really is a case-by-case basis depending on what's going on with the resident. But yeah, trying to do the least restrictive approach is actually what CMS recommends. So PPE, or personal protective equipment, also should be readily available for staff to put on when a resident's in isolation, and for any procedures that might require it, such as splash or droplet producing procedures. Also, any staff who's wearing PPE should be educated on how to put it on, how to take it off, and do that all appropriately. And then they should be competencied on this. This should be in their educational record, and this is one of those things that should be easily producible for a surveyor should they walk in. Any staff wearing PPE needs to be well educated around that, including your EVS staff or anyone who's going in the room where a resident's been isolated. And there's a guideline for isolation precautions on there you can refer to right there at the CDC. So let's talk a little bit about hand hygiene regulations and guidelines. This is something I could talk about literally for an hour and a half, and we actually have another presentation that we do all around hand hygiene and hand hygiene regulations. I'm not going to talk about it too terribly much, but what I really want to do is point you to some resources that you can use to improve your program, and also let you know that there's really 4 primary agencies that are providing regulatory oversight for hand hygiene programs in the US. These include CMS, OSHA, the FDA, and your Consumer Product Safety Commission. there's a lot of evidence that says that if you do hand hygiene and you do wear your PPE and you do your gloving correctly and your gowning correctly, it helps to reduce healthcare associated infections. But despite this, it's really tough to get folks to adhere to this, right? I mean, I think we all know the challenges of getting people to wash their hands. So NHSN actually has a surveillance module that helps improve these practices in the long-term care setting. It's open to any sort of long-term care facilities. It's any nursing homes, skilled nursing facilities, chronic care facilities for the developmentally disabled, assisted living, residential care, it doesn't matter where you're at, you can do this particular module and it will help you to improve your program. And what the expectation is that you monitor hand hygiene after healthcare personnel come in contact with a resident or any objects and surfaces within the immediate vicinity of the resident. And that's a little bit different than acute care. In acute care, they have you monitoring before and after. But so they just want you to monitor after. And what you need to be doing is a minimum observation number of at least 30 observations. And they should really be unannounced, which means that your workers don't know they're being observed. You could have secret shoppers that do this. And these are people who are trained to make the observations and then report back to you or your infection control officer, whoever it might be, quality folks. And they could be anybody in the facility that you've trained to do this. Student nurses are great at doing this, but your therapist can do it. Your case managers could do it. Your EVS workers, any activities personnel, anyone really in your facility that's out on the floors a lot can be trained to make observations and report back findings for this particular component of the module. And after the reports are made, the outcome is measured by calculating the number of hand hygiene that has been done or performed correctly over the number of total opportunities. So this is really just the resources for you guys. And these are really, really great resources. There's just a plethora of information out there that can help you to improve your hand hygiene program or develop a better one, or even develop one, in general. If you don't have a good one developed, there's tools and toolkits in all of these different resources that can help you. So, the CDC has one out, the WHO has one out, the Joint Commission has one out, the Institute for Healthcare Improvement has one out, and they've all put out these programs and toolkits. They have sample policies in there. This all can really help you to improve your hand hygiene program. And sometimes it feels like you're really banging your head against the wall because you can't get people to wash their hands, or your hand hygiene really just feels abysmal, or you've been cited, for this. And so if any of those things are true, then go to these places, pull up their toolkits. They're all free. You can download them and look at them, and they'll really help you to improve your hand hygiene program. So that's really it with when it comes to hand hygiene, and there's so much more I could talk about around that, but we just have so much to cover. So I do want to just mention a couple things about safe handling of linen. For safe handling of linen, some just real basics should be followed. And these include, you really got to consider all linen contaminated. Any bags that are visibly soiled or wet should be double bagged. You got to use leak-proof bags. And people handling linen should bag the linen at point of use. And, this was something when I was working as the educator and infection preventionist in a long-term care setting, we got cited for this. There was a CNA who was changing linen and she put it on the floor, and there was a surveyor there. So they should not be putting it on the floor. They should immediately be putting it in a bag, and then try not to shake them up or agitate them too much. If you do that, sometimes organisms can spread that way as well. So, and then also if you're handling contaminated linen, especially really contaminated linen, the person who's handling that linen should be wearing appropriate PPE, and that may include gowns. A lot of times when beds are changed or things like that, a gown may be needed to be worn. Especially when somebody has really messed the bed very badly. And then education around this also should be well documented in the employee's file. And again, you should be able to pull it out when a surveyor comes in. It should be readily available when a surveyor comes in and asks for it. So, I don't know what your facility does, but some long-term care facilities contract with off-site laundering. Some don't, but if the facility does have an off-site laundering that is happening, somebody actually should be visiting that facility. So your infection preventionist is really the one who does this, and they need to actually physically go to the site once a year to ensure that they're being compliant with the expected regulations around linen. So, some of the regulations is that laundry facilities, either offsite or onsite, really, there has to be hand washing stations readily available. Soiled linens are not to be left in the machine overnight. That really promotes growth of microorganisms, so that's a big no-no. If chutes are used, bags should be really well secured. They should be tied before they're placed down the chute. And then, of course, there's specifics around temperature, time of washing, time of drying, stuff like that should be followed, as well as certain, whatever concentrations you're using of the soaps and bleaches and things like that. So your infection preventionist should go, they should visit, they should document that they visit that, and then that should be placed in your infection control committee meeting minutes, as well as your infection control binder, so that when surveyors walk in, you can produce that and say that you have done that. All right, well, this is a good lead in to talking about the environment. So we've just talked about linen handling, and let's talk about what happens in the environment. So we know, that the environment plays a role in the spread of infection. Not just contaminated surfaces, but shared portable equipment and all sorts of other things. The cleaning of surfaces and equipment is challenging to keep up with in a long-term care facility, right? Because we know that these rooms are occupied for long periods of time. This may be the resident's home. They might have been in the same room for years. But it's really important to understand there's increasing evidence to support the contribution of the environment to disease transmission. And every facility, because of this, should have a very comprehensive environmental disinfection plan that they follow with really well-rounded policies and procedures. And these policies and procedures are there to really help guide staff in what to do for cleaning the environment in long-term care settings. It actually can be a little bit confusing about who is supposed to clean what. You may have maybe a unit where you have IVs running, and there's the IV pole and the IV pump. Well, who cleans that pump? Is it your EVS worker? They may be terrified to touch that pump. They may not be cleaning it at all. So then, well, is it your nurse that does that? Is it, one of your healthcare personnel that does that? Do they know that they're supposed to do that? And if they don't know, how long has it been since that IV pump was cleaned? And that's just kind of one example. But that's, when we were talking about the citations, the frequently cited things in FTAG citations, medical equipment that wasn't clean is one of those citations. And a piece of that is because there's no clear guideline or policy that tells the staff who is supposed to be doing what. So it's such an important piece of what you do in an infection control program is to guide your staff to, let them know who is supposed to be cleaning what and how they're supposed to be cleaning it and with what types of disinfectants they're supposed to be cleaning it based on the manufacturer's guidelines. This might be one of the most challenging things you have to do in infection control because there's a lot of different regulations around this. Each piece of equipment might have a different recommendation on what kind of disinfectant to use or how to clean it, but you actually need to know that. You need to know what every single piece of equipment in your facility is supposed to be cleaned with and how often, and then that should be in a policy or procedure, and your staff should be well trained around that and be able to speak towards that when a surveyor comes in. So this is just kind of a nice study that was published in IPCO in 2010. And it shows that, healthcare workers contact surfaces near the patient bed really the most often, which makes obvious sense, right? But the study also shows that these particular areas have really high levels of microbial contamination. But that doesn't mean that other things in the room don't have contamination. Almost everything in the room is going to be contaminated. So good cleaning and good focus on environmental disinfection is so key. Your EVS workers are such a huge part of your infection control program. They should be well educated. There should be lots of kudos given to them for a job well done. And then there should be feedback, for them if they're not doing what they are supposed to be doing. So there's really common transmission routes of pathogens, which include such things, that, like we talked about, like contaminated surfaces in the rooms with active infections. If a resident has an active infection, there's these surfaces in the rooms are very highly likely to be contaminated with whatever it is they have. So if they have C. diff, there's going to be C. diff on those surfaces. If they have VRE, there will be VRE on those surfaces. And then, disinfection and cleaning strategies that can help really mitigate the routes of transmission include a really good job of terminally cleaning a room when a resident's discharged, and then doing a daily disinfection of those surfaces that are touched a lot, but also other surfaces as well, ensuring that there's really good disinfection. Also between like portable equipment, if something is shared, it should be disinfected between each and every use. And when it comes out of a room and goes into another patient room or resident room, it has to be disinfected before it goes into that room. And then just general improvement of cleaning and disinfection of common areas and shared resident areas. And this slide just kind of shows, special considerations in long-term care, because there are so many shared areas. There's rehab areas, there's those activities areas, common dining areas, or shared shower rooms. All of these should be particularly well cleaned, and there again should be policies around who cleans what, how are they cleaned, what's the manufacturer's recommendations around the cleaning, what kind of disinfectant is supposed to be used for each piece of equipment. Are you following it correctly? Making sure also that your stuff is not expired, like your disinfectant is not expired if it's in that room, especially rooms that aren't maybe used very often. And also, if you're using glucometers, any sort of actual individual finger stick device should only be used for one person. But then the glucometer itself can be shared, but you've got to disinfect it and disinfect it correctly between each resident. If possible, you should really try to give a resident their own glucometer. That's really best practice. But if you can't, you got to disinfect those glucometers, and you got to do it correctly between each and every patient, each and every use. That's very important. You'll get cited for that every day. So this is another issue, right, that it's kind of an emerging issue because it's the digital age and there's phones everywhere. Everybody has a phone. There's lots of touch screens now being used in long-term care as well as acute care. And these screens, they harbor bacteria, believe it or not. If you're not cleaning these screens, you should be cleaning these screens. So, bacteria can survive for months on the surface of a dry touch screen, believe it or not. Like C. diff is a great example of that. Touchscreen devices are going to have at least one bacterial culture probably on them, if not more. And the culture, it could be anything. It could be MRSA, it could be staph, it could be strep, it could be all kinds of different things. So disinfecting your digital screens with something, and usually it's just a straight 70% alcohol that would be used for that, a wipe. There's several different things available on the market right now that can be used for that. And people should be disinfecting their phones. They should be disinfecting these screens. You should be disinfecting, the keyboards and the mouse that you use every day. And that disinfecting wipe should be right next to these touch screens. So that's an important piece of preventing infection through these digital screens. It's something that we just don't really think about, but it is a vector for transmission. It definitely is contributing to infections in long-term care now with this digital age. So let's just very quickly talk about kill claims and contact times for disinfecting of products. The contact time listed on a product label is the total amount of time that it takes to inactivate all of the microorganisms listed on that product label. This is also known as the kill claim, right? So this time is typically referred to in minutes on the actual wipe. Your staff should be able to state very easily how many minutes your wipes take to kill something. When a surveyor comes up to them and says, how many minutes should this remain wet? The staff member should be able to easily say, oh yes, well this wipe only takes 2 minutes, to disinfect, or this wipe only takes 4 minutes to disinfect. But the thing is that EPA guidance requires that the treated environmental service or equipment remains wet for the contact time that's stated on that product label. And if you're living in a state that's dry, like Phoenix, for example, a wipe that takes 5 minutes for the wet time, more than likely is going to be drying before that time. So you're going to have to get another wipe and re-wet it and make sure that it stays wet for that total amount of time that's listed in minutes on the product label. And that's kind of a bummer, but that's the way it is. That's the guidance for right now. That may change in the future, but for right now, that's what your staff should be following, and that's what your staff should be doing. It needs to remain wet for that full amount of time that's stated on the label. All right, let's go to employee health programs. So an employee health program is really a central part of your infection control program. High-level goals for your employee health program needs to include like education and training of employees around basic principles of infection control. That's just one piece. And then, providing care to workers who might have a work-related illness. That doesn't mean that you have to actually give them anything, but you need to be aware if one of your employees is sick, you need to at least be aware of that. So the employee health nurse, they can be an infection control nurse as well. That's what I was. Actually, I've had dual roles in many different places where I was the infection control and employee health nurse. And your employee health nurse maintains the confidentiality of your workers, but they should be contacted and at least know when you have sick employees. And this is important too, because you can catch outbreaks if you have several people calling in sick to work. If you can get some symptoms from them and they say, oh, I have a cough, sore throat, fever, you might be like, oh, we may have a flu issue going on. There was actually an experience that I had where I had people calling in saying they had horrible, terrible rash on their body. Come to find out, we had a scabies outbreak, which was super fun to have to deal with. But that was actually the way that I caught it. I didn't even catch it from a resident end of things. I caught it from the employee letting me know what was going on, the employees that had this issue. And it really helped to head off a way bigger problem in that facility. So, that's an important piece as well of an employee health program. So the specifics around the employee health component of the regulation state only that you have to keep employees with skin lesions or communicable diseases from contact with residents. But there's a lot more that's got to be included. And, besides what I've just talked about, you need to be doing immunization programs for your employees, at minimum, hepatitis B and influenza, and then your TB testing. And depending on what is going on with your facility, you may not test TB every year, but you should at least be, doing your exposure risk assessment for your facility. And then, doing the TB testing as often as your risk assessment says you need to. And then, for your flu program, you've got to consider that any person coming in and working with your residents should be immunized. This is something you should set up ahead of time. You should let anybody who's coming in the facility, working with your residents, know that they are expected to be immunized. If they cannot get an immunization, a flu shot on their own, then you should provide it for them free of charge. And so this includes, any physicians that are contracted to come in, maybe specialty physicians or something like that. Any workers, like maybe you have some construction workers that are actually working in your facility doing some sort of project or something, and they're going to be around residents or in common areas where the residents are at. They should be immunized. Anybody that's going to be close to your residents or in your facility should be immunized, and you should provide them that flu shot if needed, or at least tell them that they're absolutely required to provide proof that they have been immunized prior to coming into your facility. That's going to be so key for your residents who may not be protected from the flu shot for the entire year because their immune system, again, is going to wane. So oftentimes flu shots for residents last less amount of time than they do for healthy adults. Okay, so if I've lost you and you've drifted away, this is a really important time to come back because this is going to be super important for you. This is going to be probably the #1 key for you to be able to really get yourself a good infection control program. This is the CDC's website. And on the CDC's website, there is a toolkit specifically for long-term care, which helps you to know if you're actually meeting all of these things that I'm talking about. It helps you to assess your own program internally and go through every single thing that is required of your program. It's all listed right there in that infection control assessment tool for long-term care facilities. So go to their website, pull this up, and do this for your facility. This will help you to identify gaps or any sort of thing that's going on in your facility that might be an issue or that you have not already implemented. It will help you to do this. This is kind of what it looks like. It has the element to be assessed, and then it goes through absolutely everything that you need to do. All the things that we've already talked about. Are you doing those things correctly? If you're not doing them correctly, then you just check mark no, and then you take steps to fix that issue, right? So pull this up, go through this, go through every single element on this list, and if you can check mark that you're doing them all, then you are ahead of the game. You have a great infection control program, and you've got it good, and you've got it going on. But if you don't, then you can identify the things that are an issue, and you can take steps to fix those things before surveyors come in and find them. So this is a really great tool. If you don't hear anything else in this particular webinar, this will help you probably the most of anything. So go there, print this out, and do this for your facility. Okay, let's talk really quickly about antibiotic stewardship. The CDC, has stated that antibiotics are among the most frequently prescribed medications in nursing homes. So up to 70% of residents in a nursing home are receiving one or more courses of systemic antibiotics. And also, they're showing that probably 40 to 75% of these antibiotics are unnecessary or inappropriate. And, these residents can be seriously harmed if they're taking unnecessary antibiotics because they can get infections that they don't even need because they've been on a course of antibiotics, such as C. diff. And there might be an adverse drug event or a drug interaction. And then eventually, if they're taking too much antibiotics, they may end up becoming colonized or infected with antibiotic-resistant organisms, which then get passed to other residents. So it's a really big issue. And this has really become a national priority, right? So, the CDC and the government in general is just really focused on decreasing antibiotic use that's unnecessary. So your antibiotic stewardship program, there's actually a CDC guideline, which is the management of multi-drug resistant organisms in healthcare settings. And it states really that you've got to have attention to judicious antimicrobial use. And there's a lot of educational tools in this from the CDC that have been launched to really promote improved use of antibiotics, both in acute care settings and in long-term care settings. So, the CDC's really highlighted the need to improve antibiotic use. They've said it's one of 4 key strategies required to address the problem of antibiotic resistance in the US. Antibiotic resistance is a growing problem. It really is an issue. We are not going to have any antibiotics left if we don't take care of this problem. And long-term care settings are every bit as key, every bit as acute care settings or outpatient settings or community settings for preventing, the development of these resistant organisms, which are a real threat. They are a real threat to everyone, not just long-term care folks, but you, me, our children, everyone. So we've all got to really do our part for antibiotic stewardship. Core elements for antibiotic stewardship includes getting your leadership on board with a commitment of support. They should be helping you with this. So you should have like a lead physician. You should have a lead pharmacist that should be helping to head up the program and helping you monitor antibiotic stewardship activities in your facility. If you don't have that, or you don't have anyone that's willing to do that, there are consultants that are available. They might be able to help you get initially started if you don't have anyone that's willing to jump in. And then after you get something established, there should be at least a few actions that happen. So take at least 1 action or 2 actions that will help to reduce antibiotic use in your facility, or unnecessary antibiotic use, I should say. And then track your progress and report back to your nurses and to your physicians in the facility. And do some ongoing educations for your physicians and your nursing staff. And also residents and families have to be included in this too, because sometimes they'll ask for antibiotics. Like, I have a cold, I have a sore throat, give me some antibiotics. And that's not necessarily what needs to happen. So you've really got to educate residents and residents' families around this as well, that you are really focused on only prescribing antibiotics for people when they absolutely need it. And there has to be a very good reason. So there are actually some really good CDC resources around this. Go to the CDC. There are 4 different booklets here. They're easily downloaded, again, free. Print them out if you don't already have a good antibiotic stewardship program. This will help you a lot for getting started and continuing to improve your antibiotic stewardship program. Again, there's just so many good resources out there. And I hope, again, if there's really nothing else you learned from this webinar, that I've pointed you to some great resources that will help you to do all of these different things that are required for you in your infection control program. So go to these particular booklets, download them, see if you're doing what you should be doing according to the CDC for antibiotic stewardship. All right, so we are getting almost to the end here with phase 3. And phase 3 goes into effect in 2019, and this is kind of talking about that you have to have this quality assurance committee, and you need to have an IP that's actually sitting on this committee. So who is an IP? Like, what is an infection preventionist? What does that even mean? And how can you get one in your facility, right? So qualifications of an IP, or an infection prevention and control officer, that in order to meet this phase 3 includes that the IP has to have primary professional training in either nursing, medical technology, microbiology, epidemiology, or other related field, and that they're qualified by their education, training, experience, or certification. So it's kind of nice to know that you don't necessarily have to have a nurse as your infection preventionist. It could be somebody else, but they do need to have a good background in infection control, and they really should be certified. And the certification in infection control, or CIC, which is what I have, really shows competency in all areas of infection control and prevention. It is the preferred certification for an infection preventionist, and this is through ABCC, which is the Association for Professionals in Infection Control. So people who do this certification are board certified in infection control, and that's really the person that you want to have in your facility that's running your infection control program. If you don't already have this, or somebody is doing your infection control program that's not certified, it would behoove you to see if they would get certified. So tell them that they should, start studying for this and sit for the exam. And then you'll have somebody that when the surveyors walk in and say, do you meet this regulation? It's 2019. Do you have somebody who's trained? You can just pull out the certification and there you go. So that's one way to really show that you have somebody who is meeting that regulation for the FTAG. So this is just sort of, a day in the life of an infection preventionist. Definitely, we do a lot of things, not just surveillance, but, there's product evaluations, there's, if there's any sort of construction going on, the infection preventionist should be very involved in making sure that the spread of organisms is not happening during that construction process. Infection preventionists are very involved in education, not only for your EVS workers, but for pretty much everybody in the facility. An infection preventionist should be doing some sort of new employee orientation on infection control and infection control prevention and strategies and or the policies and procedures around this. And then, if you're sterilizing or disinfecting any sort of instruments in your facility, they also do that. And they do just so many other things, but, you're a well-trained infection preventionist is important in your facility. So this is just sort of quality committee infection control tasks. This is something that your infection control committee should be doing. We've already talked about a lot of these. I'm not going to really go through them again, but surveillance, really establishing those policies and procedures, making sure people know what they're supposed to be doing, when they're supposed to be doing it, and then all of the education around it, the competencies around it, and making sure that all those things are easily producible for a surveyor should they come into your facility and ask for it. And then, your annual review of your infection control program, which we talked about, so important to make sure that you've gone through every thing that's expected of your program, checking those boxes and seeing where your gaps are at, and then taking steps to fix those issues that you've identified. So people who are on this committee, we've already kind of talked about this as well, but your infection preventionist, your chief nursing officer or DON, a lab manager, your pharmacists, clinical educators, and your quality department, and any sort of nursing director. So you can have more people on there, but this is probably the minimum that should be sitting on your quality committee, which you can combine your quality committee with your infection control committee. Some people choose to do it separate, but you can do it together if you want to. These committee meeting minutes are so important to show that you are, you're going through all these different steps that are required for infection control, and you've documented that you're doing that. So, I have been asked, I can't even tell you how many times with surveys, to produce my minutes from my meetings. And if you take really good minutes, and if they come in and they identify a problem in your facility and they say, oh, there's this big problem going on, what have you done around that? And you can pull out your meeting minutes and show, you can show, well, we did identify that and we've talked about it, and this is what we did. And you've documented that in your committee meeting minutes. That can actually really help you. So take good minutes and keep that somewhere that's easily producible when you have a survey. So, we've talked about a lot of things, but in summary, we know that, FTAGs associated with infection control are very frequently cited. Your long-term care population is super high risk for infections. And to be in compliance, you've got to, you've got to understand the new requirements. You've got to put these programs in systematically with the right sequences and have them able to be shown to your surveyors when they come in. Education, 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 so important. Make sure you're getting that done. Try to do some creative, fun ways of learning. And then monitoring your surveillance and doing some feedback. Some positive reinforcement goes a really long way for doing that as well. But that is the end of our presentation today. And thank you so much for joining us.